Welcome to the Pot of Inquiry, everyone. My guest today is Amit Lakkaraju. Dr. Lakkaraju was a guest of mine just about 6 episodes ago, and we had a fascinating discussion at that time regarding stellate ganglion blocks and some of the different agents that we used, and wanted to have him come back to talk about his work that he's doing with venous insufficiency and other venous disorders. And it's pretty extraordinary what you'll see in his presentation today, and I think you'll get a much better understanding of how not only the aberrant physiology affects these nerves, and he talks about perivenal phlebitis and how that can affect some of the nerves. And we also get into a discussion with different types of venous ablation techniques and which are more likely to cause saphenous and sural issues. So please enjoy this great episode I have with Dr. Amit Lakkaraju.
Welcome to the Pot of Inquiry. Ready for some thought-provoking cerebral whipping and the destruction of ridiculous medical dogma? Want to shift those stale, moldy old paradigms? Well then, don that thinking cap of yours, get down in the cave, and join our host, Dr. Stephen Barrett, for this week's episode. Let's start spelunking.
Welcome to the Pot of Inquiry. I have Dr. Amit Lakkaraju, who was on a few episodes ago. We had a fascinating conversation about stellate ganglion blocks and got into some very cool stuff about D5W. And so I asked him back to share his expertise on venous disorders and coming at it from a little bit different perspective from a chronic pain standpoint. So Amit, thanks for coming back. I really appreciate your time.
My pleasure, Stephen. It's great to be back on the show.
Great. So tell me what we're going to talk about today, because I'm pretty excited to learn from you.
All right. So I thought I'd chat a little about varicose veins, venous insufficiency, just the breadth and depth of the issues that come up in the lower limbs, and the management of these issues. So basically, if we look at most populations, between 20 and 30% of the population has some sort of venous insufficiency. Wow. And it progresses as time goes on. So you'll have people who have tiny spider veins, telangiectasias on the back of their legs or on their thighs, going up through the visual varicose veins that a lot of people have, to finally getting into the realm of large ulcers or venous eczema or a lot of swelling in their legs. So they can present with quite a few symptoms and signs, one of which is pain, which is where I got into this.
Yeah,
right.
So let me ask you about that, because, after decades in practice, I can't tell you how many people have asked me about their varicose veins, and it's something that we kind of like, well, if it's really bothering you, then we, send them off to a vein specialist. But I don't really recall anybody telling me that it was painful. It usually was more of an aesthetic type of issue for the patient. So I'm interested in that.
Yeah, so a lot of them will complain more of an aching of the back of their legs, in their calves, or sometimes in the anterolateral compartment. Sometimes the veins themselves are quite painful, itchy. A lot of them will also have some amount of restless leg, and sometimes the pain can be associated with neuropathic disorders. So sometimes the veins themselves can give rise to either sural nerve or saphenous nerve neuropathy.
Right.
Or they can be part of the spectrum of issues that patients with peripheral neuropathy suffer from.
Well, that's interesting. You mentioned the saphenous nerve, because looking back on it, it's not a lot of people, but it's probably a fairly more than a handful of patients that have had either a venous ablation procedure or some type of procedure And the saphenous nerve ended up getting entrapped, or in a couple of cases, frankly, just damaged. And I
Yeah.
rarely saw that. I mean, yeah, I saw a handful of them, but there's hundreds of thousands of people that are having these things treated. And
Yeah.
so that's got to be probably pretty small number that have that complication.
Correct. Yeah.
Yeah.
I think you're looking at sub 1%
Okay.
post treatment that actually have saphenous nerve issues. The sural nerve is more commonly involved post ablation. The saphenous nerve really comes into play when the great saphenous vein below the knee comes in close proximity to the
Right.
saphenous nerve. Whereas at the back in the calf, you've got the sural nerve coming in close proximity to the short saphenous vein.
Right.
So if people are ablating or injecting and they prang that nerve or injure it, thermally injure it in some way, that's where you can get sural neuropathy. Now, as you know, the sural nerve is quite a irritable nerve.
Oh,
So
the sural nerve doesn't even like you looking at it.
yeah, tell me about it.
No,
So
it's a son of a gun, isn't it?
yes,
Yeah.
yeah,
Yeah.
absolutely.
So let me ask you this, because I know that there's basically laser ablation and then radiofrequency ablation. And I was
Cool.
told at one time that there's a higher incidence of saphenous, or let's say maybe both,
Yeah.
sural and saphenous, a higher complication rate with the laser than the radiofrequency ablation. Is that true, or am I getting
Um,
that backwards?
no, I think that I think you're right. The There's evidence, and then there's anecdotal experience. I
Right.
think that anecdotal experience in this case has been uh, perpetuated as a true issue with laser. So, as you said, there are two methods of treatment. So you got laser. We use 1410 or 1970 nanometer endovenous laser fibers. So they're actual, what you call it, light emitting fibers that you place into the vein
Right.
via an introducer. And then how it works is that because the laser wavelength is equivalent to the red blood cells, you actually coagulate the red blood cells. So it's a heat-induced destruction of those red blood cells, which then produces the thermal what you call it, coagulation of that vein.
Okay.
And what we're trying to do is, by closing that vein up, you're redirecting circulation away from this vein that isn't working to another one. Radio frequency, obviously, use higher temperatures.
Okay.
So radio frequency uses about 120 degrees. Laser tends to get up to about 1,000 to 2,000 degrees.
So
Heat.
so then this might be a thermal phenomenon, because
That's right.
you're just your thermal energy has to go somewhere, and if you've got that
Yeah.
nerve running right along that
Yeah.
vein,
Yeah.
that's
So
interesting.
usually, whichever method you use what we call tumescent anesthesia. You might have
Right.
used tumescent.
Yep.
So we basically flood the saphenous fascia with a solution called Klein solution, which is a combination of 1% lignocaine with 1 in 100,000 adrenaline, 0.83% sodium bicarb, and normal saline. And so
Okay.
you fill that space up, and collapse the vein around your fiber, whether it's laser or whether it's radio frequency catheter, and
So
then
you
you
so
close it up.
let me interrupt you, because I'm not sure I understand. So the tumescent anesthesia, and for people that don't know what tumescence is, it's basically swelling. and you're putting in a large volume of fluid in a space, and
Yes.
you accomplish some local anesthesia just because of the tumescent effect.
Yep.
In addition to, you know, the small amount of lidocaine or in it. But
Correct.
does that also act as a thermal guard?
Yeah,
Because
that's exactly right. So
okay,
it's basically it takes away the heat to the
okay,
surrounding tissues,
right,
and that's how you maintain the general. You prevent that heat-induced injury. One of the things is that when you do the tumescent anesthesia, you use a tumescent pump. So we're
okay,
using something like 60 mils per hour. You know, there's a pressure that actually hydrodissects the fat and soft tissues away from it, and
from the vein.
therefore from the vein.
Okay,
Uh,
so you're getting a mechanical separation as well as a thermal blanket or a layer of
that's
protection.
exactly right. Yes,
Okay,
yes. So
okay,
you heat protect it and release it up, and so traditionally what's happened is that when we do the great saphenous vein, we tend to just ablate the thigh segment of it. So
okay.
from the saphenofemoral junction,
Hmm.
which is next to the femoral nerve, all
Right.
the way down to the knee joint. What has
And that,
become
let me interrupt you again,
yeah,
because almost always when I've addressed a post-venous nerve issue, it's been in the thigh, like right up close to the adductor canal.
that's right.
And so what you're saying is that you're going from there down to roughly the knee, and then everything else just shuts off after you've done that segment?
Yeah,
Okay.
that's exactly right. So
Okay.
the because the saphenous nerve in the adductor canal isn't anywhere near the great saphenous vein, you shouldn't get that thermal injury
You're
to
right.
that. So often what happens is that when you ablate these, you get propagation of the heat-induced thrombus down the great saphenous vein below the knee joint.
Okay.
And that's where the great saphenous vein then starts coming in close proximity to the saphenous nerve. So when there is a heat-induced saphenous nerve injury, often it's because there is inflammatory reaction of the great saphenous vein, which then involves the saphenous nerve below the knee joint. Does that make sense?
Yes, it does. It does.
So, so the saphenous nerve is quite far away most of the time from where you're doing the ablation, or should be anyway.
Interesting. So explain the concept to people, what you're trying to accomplish by basically you're taking a pipe that's patent or open, and you're closing it down,
Yeah.
and you're trying to shift the circulation from a venous standpoint from the superficial to the deep. Is that what the goal is?
Yes, that's
Okay.
exactly right. That's
Okay.
exactly right. Your most of varicose vein disease is caused because the valves aren't working properly.
Right.
So there are 24 valves in the great saphenous vein. With the degenerative process that's occurring in varicose vein disease, those valves stop working. So instead of being one-way valves, they
Right.
become they start allowing that backflow into the varicose vein. And every time you calf pump, so if you're
Right.
walking, if you're running, there are connections between the deep venous system and the great or short saphenous vein. So every time you calf pump, you push or squeeze some of that blood into these varicose veins. So there's back leak occurring
Right.
because these valves aren't working, and then there's this sort of forward leak or antegrade leak from the deep system. So they
So
basically become bags of sluggish flowing venous blood
right.
that then cause low grade inflammatory processes. So you get a low grade phlebitis.
Okay.
The veins also become very porous. You tend to get
A lot of extravasation.
that's right. And then
Right.
the red blood cells which extravasate out break down. You get hemosiderin deposition.
Right.
Hemosiderin is toxic to the local microenvironment. That produces an inflammatory reaction. You get pigmentation along the vein. You then get skin changes, venous eczema, and as time goes on, ulceration. So it's basically like a river that's overflowed its banks. And so you've got a marshy surrounding area that really doesn't tolerate tissue very well.
So let me ask you about these valves. The way I always thought about them is that, they're kind of like a fish ladder where, the fish could jump up and then the water would stay there and then it could.
That's exactly right. That's exactly right. So it is exactly that. It's a salmon ladder that,
Right.
should be working only in one direction. But because varicose vein issues are happening, because these valves are degenerate, you then get this back leak because of gravity.
Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor. I'm constantly exploring new avenues to enhance well-being and address any health concerns. Today, I'm thrilled to introduce you to an exciting supplement called Stem Regen, which I take daily and genuinely believe could revolutionize your health journey as well. Stem Regen stands out as a game changer in the realm of wellness. Crafted from 5 potent plant extracts, it boasts a remarkable ability to stimulate the release of your body's own stem cells from your red bone marrow. Why is this significant? Well, stem cells are the superheroes of our body's natural repair system. They possess the extraordinary capacity to morph into various cell types, aiding in tissue regeneration and repair. As we age, the quantity of circulating stem cells in our system reduces significantly, impairing our body's ability to heal and rejuvenate itself effectively. Stem Regen steps in to counter this decline by kickstarting the release of stem cells into circulation, thereby bolstering your body's innate repair mechanisms. Once unleashed into your bloodstream, these mobilized stem cells actively seek out areas of damage or injury, initiating the healing process. By incorporating Stem Regen into your daily routine, you're essentially empowering your body to tap into its own regenerative prowess more efficiently. I firmly believe that Stem Regen could be a valuable addition to your wellness regimen, especially if you're seeking to fortify overall health and vitality, accelerate tissue repair, or expedite recovery from injury or illness. This first of its kind stem cell mobilizer is changing the game in regenerative medicine. Don't wait to unleash your body's innate healing capabilities. Visit stemregen.co/Dr. Steven, that's with a PH, and use the code SBPOD to get a 15% discount off your first order of Stem Regen. Hey Spelunkers, we're thrilled to kick off Season 6 with a fresh new look and the most exciting content we've ever delivered. This season, we're diving deep into the fascinating world of human optimization and understanding. But wait, there's more. We're giving back to our loyal listeners with an exclusive giveaway each and every episode of Season 6. That's right, prizes are waiting just for you. So how can you join in on this fun? Well, it's simple. Follow us on Facebook, Instagram, and LinkedIn. Subscribe to our YouTube channel, and here's the magic touch. Comment, "Let's Spelunk" on any of our Season 6 YouTube videos to enter. Of course, please add anything else you'd like to your review. Don't miss your chance to explore, learn, and win with the Pod of Inquiry. Let's spelunk into the wonders of Season 6 together. All right, so you said there's 24 valves usually in the great saphenous vein.
Yeah.
Are they, is it the same amount of valves in the deep venous system?
So yes, there are not the same amount, but there are similar sort of valves in the deep venous system, although they are not as integral to the return of blood as
because of the muscular contraction.
Correct.
That was the one thing that I could never quite understand, because
yeah.
all right, so let's say we've got bad valves in our great saphenous vein. What's to keep them from being bad in the deep venous structures?
Well, they do, and you can sometimes get deep venous reflux in addition to what you call it, superficial venous reflux. But if you deal with the superficial reflux, in most cases, the deep venous reflux tends to normalize a lot more.
So I'm trying to get a concept of this, because what I'm thinking is that I always like to have a visual that I can give to a patient so that they can kind of understand a little bit. So let's say we have this muscular container, which is our calf muscle.
Yeah.
And inside that, we have the deep venous structures.
Yeah.
And then outside of the calf muscle container, we have the superficial. So when the patient is walking, the muscular contraction is really affecting the deep venous structures positively.
And to a certain extent, yes, and to a certain extent, the superficial venous structures.
But not as much, because they don't have the pump all the way around them, right?
That's right. That's right.
All right. So you helped me there. I really didn't know that, because I could never get I could never get over the abyss between, all right, well, if I've got a venous issue superficial and I got bad valves, well, how are the bad valves any different in the deep venous? But now it makes sense, because not so much of the internal environment of the venous structure, but because of what's happening externally.
That's right. That's exactly right. And the other thing is, so we've talked about the superficial system, we've talked about the deep system, but we really haven't talked about the spider veins, the telangiectasias.
Yeah.
And they're the third system. They're basically fed by the superficial system.
Okay.
So every spider vein has a feeder vein, a bit like an aquifer leading up to a river.
Okay.
So you can make a case that people who have some degree of spider veins have some degree of superficial venous insufficiency.
Well, that would be pretty empirical, wouldn't it? Because
that's right.
I mean, you're not going to just, unless there's some local phenomena going on that's causing an obstruction, right?
That's right. And then you also find that a lot of patients who have had scars, for example, a traumatic scar from, say, a foot, a
bad laceration or something,
injury, or
right.
You'll find that there's a whole bunch of veins around that scar. And it's primarily because the scarring has given rise to a local phenomenon of venous insufficiency in that area.
So let's say if you've got a patient that's got a fair amount of telangiectasias, and you don't address them specifically, but you address the GSV.
Yeah.
Do they just kind of get better because now you
No. And this has been the fallacy with treating venous disease. The idea has been that if you get rid of the great saphenous vein, then you'll sort out the venous incompetence. But we know that despite you closing off a great saphenous vein, the varicose veins from that continue to get flow. Yes, they'll become smaller, but they will still flow because they'll recruit venous flow from other sources.
Oh,
so
so it's a collateralization phenomena or something like that?
That's exactly right. So there's a collateralization phenomenon. So essentially what the present thinking around the venous specialists is that if you're going to deal with a varicose vein, you got to deal with the whole network rather than just the feeder. So say, for example, you've got varicose veins in the thigh, and by just and in the calf, by just dealing with the great saphenous vein, you'll have an initial period where the surface varicosities will become less, but then they'll become large again. So we then use something called sclerotherapy. So ultrasound guided sclerotherapy has become a very effective manner. It's just multiple injections of a sclerosant. So there are three types of sclerosants. You've got sodium tetrodosi, STS. You've got ethoxysclerol or polydocanol. And then you've got things like hypertonic saline, 23% saline. So you can use...
What's your drug of choice for that?
Polydocanol. I use polydocanol. So it was a local anesthetic sort of in the past.
Okay.
But then they started finding that when they were developing, it was a really effective sclerosant. So we use it now primarily for sclerosants in the setting of varicose veins. That's what its indication is. So we close off the truncal vein, whether it's the great saphenous vein or short saphenous vein, with laser or radio frequency. So use a larger, a more stronger thermal ablative method to close off the large veins, and then the side veins we inject now.
So when you're putting the sclerosing agent in these telangiectasias,
not only telangiectasias but varicose veins also.
Okay. Are you trying to find that main feeder, or are you just taking it?
Yes.
Trying to. Okay.
Yeah. So basically, what you're doing is you find the source of that,
right,
and then you go and you inject that vein from the source along its course. And so you do multiple injections because the sclerosant denatures beyond about 5 centimeters or so, or there's a time period and a distance period. So you do overlapping injections along the vein.
All right. Now, there's a lot of cosmetic play in the little spider veins for ladies, and I mean, I don't want to be gender insensitive here, but I've really never had a male patient come to me that was bothered by a little spider vein. You know, it's like, it's just one of my battle scars, move on. I got other fish to fry. But in a case where it is more of a cosmetic type of a situation, do you locally anesthetize in that area, or you just kind of hit them and sclerose it?
You hit them and then sclerose it.
Okay. All right.
So I suppose there are spider veins that are painful.
Okay.
There are spider veins that are primarily cosmetic, and there are spider veins that are actually an indicator of deep venous issues.
Right.
So I'm going to show you. So this is one of those gentlemen that walks in. You got varicose veins all the way down. So as you can see, he had a whole bunch of large varicosities up here. He had a fair bit of swelling, large bunch of grapes all the way down the leg, and you can see the difference in size one compared to the other. This was all due to a combination of great and short saphenous vein insufficiency. So this is him 6 weeks post.
Wow. All right. Now, what did you ablate there?
So we did great saphenous vein and short saphenous vein ablations and ultrasound guided sclerotherapy of the varicose side branches. So as you can see, there's a little bit of mottling up top.
Right.
So if we go back to the previous picture, that whole area has now shifted to this.
That's incredible.
All of this has now shifted to this.
Wow.
So
that patient has to be extremely happy.
He was really happy, and you can see how much change there is around the ankles with the amount of swelling that's happened. So significant improvement with basically 2, maybe 3 treatments. This is all done under a nerve block, a femoral obturator and saphenous nerve block.
Okay.
Done in clinic. So patient comes in, has the endovenous laser and ultrasound guided sclerotherapy whilst they're under the local anesthetic, walks out there 90-minute procedure. And it's a staggered treatment. So we bring him back a week later on or 2 weeks later on, make sure he doesn't have a DVT, but also go on to do ultrasound-guided injections.
So let me ask you a couple questions here. Can you go back to the pre-treatment photo?
Yeah.
What is accounting for, in your mind, the unilaterality of this? Because his right leg looks pretty good.
So often there's a unilaterality. The commonest cause of left-sided issues is because sometimes you can get what they call a May-Thurner syndrome, where the traversing right common iliac artery can cause pressure on the left common iliac vein that runs under it at the level of L5 vertebral body. So internally, where the aorta and the IVC are sitting together, you can get the common iliac artery pressing on the left common iliac vein. Sometimes that can increase the general venous pressure and give rise to it.
Right.
But sometimes it is just a matter of which side the degenerative process has occurred more. If it's a saphenofemoral junction valve issue, then you tend to get these thigh varicosities a lot more, because the saphenofemoral junction can give rise to quite a large amount of pressure going into the great saphenous vein. So the first branch that comes off the great saphenous vein, which is the anterior branch in the thigh, can become really varicose really quickly. Often there's a perforator issue going on down in the calf area, or it can be the first calf branch, the great saphenous vein, that's causing all these issues. So the key to treatment and why it's so successful is actually to map out where everything is. So when we do the initial consultation, there is always a venous mapping, and from that you can get what truncal vein is not working properly, what varicose branches you need to deal with, and from there you can go on to close up those varicose veins.
So let me ask you a question about pressures, and this is a little bit tangential, but there's a lot of conjecture, and some would say that it's gospel. I'm not sure that I believe that, but that you can have venous engorgement in fibroosseous tunnels that are running with the other neurovascular structures, and that these pressures can exceed the tolerance of the nerve that's adjacent to it. What's your thoughts on that?
I actually have seen that happen. So I am partly a believer of it.
Okay.
I'll tell you a situation. This sort of gentleman, much less varicose veins, but quite a thin gentleman, cyclist, came off his bike about 7 years ago, had a whole bunch of varicose veins, but also had quite bad neuropathic pain. Ultrasound showed significant rectus femoris scarring, and scarring of the sartorius and scarring in the subsartorial canal.
All right.
You then looked at the ultrasound of the veins, and they all sort of tend to be interdigitated with that. So we did sclerotherapy on him and prolotherapy of the scar in the subsartorial canal, and his symptoms significantly improved. So you can get that sort of situation occurring. My belief, though, is that there is more commonly a adjacent inflammatory process occurring in the vein that gives rise to the adjacent nerve issues. That's my feeling as such. I find that patients who have a low-grade phlebitis in a vein adjacent to the nerve will present with neuritis.
Interesting. Interesting. And now a message from our sponsor. The power of ketones, your body's alternative fuel. The folks at Approved Medical Solutions have done it again. That's right, with their new Clean Ketone Supplement. Imagine your body as a hybrid car capable of running on 2 different fuel sources. While glucose is your body's regular gasoline, ketones are like switching to an efficient, clean-burning alternative fuel. I would say rocket fuel. When your body produces ketones, whether through fasting, low-carb dieting, or intense exercise, something remarkable happens. These molecular powerhouses cross the blood-brain barrier, providing crystal-clear mental energy that many describe as enhanced focus and clarity. But ketones aren't just brain fuel. They're efficient energy sources for your heart, muscles, and other vital organs. Think of them as premium-grade fuel that produces less metabolic waste than glucose processing. Research suggests ketones may offer additional benefits: reduced inflammation, improved metabolic health, and even potential neuroprotective properties. They're particularly interesting for athletes seeking sustained energy and anyone looking to optimize their cognitive performance. The best part? Your body is naturally designed to produce and use ketones. It's not about completely replacing glucose, it's about metabolic flexibility, giving your body the ability to thrive on both fuel sources. Whether you're interested in mental clarity, athletic performance, or overall health, understanding and harnessing the power of ketones might be your key to unlocking new levels of well-being. Approved Medical Solutions Clean Ketone Formula contains nature-identical ketones. These ketones provide the same fuel as those produced through a keto diet. Approved Medical Solutions Ketone Formula does not contain sugar, caffeine, or 1,3-butane-diol, and they are not ketone salts. I've been using them routinely now and notice a minimum of a 10% increase in exercise performance. By diving deep into cutting-edge research and real-world applications with leading scientists and practitioners, the Pot of Inquiry illuminates the science-backed path to enhancing your mind and body's potential. You can find us on all platforms, including Spotify and Apple Podcasts. Please join us.
So I see it sometimes in patients, ladies who have just started HRT.
Okay.
I see it in patients who have had a DVT, an SVT, all of those sort of things. So I think both are viable theories. I think the phlebitis tends to be more common than the fibroosseous tunnel compression theory.
Yeah, because that's talked about a lot in tarsal tunnel syndrome.
Yeah.
And it's very interesting because you'll look at MRIs and preoperative MRIs, and you don't see anything really that tremendous from a venous engorgement standpoint. In fact,
yes,
nothing. And then when you open up the tarsal tunnel, you'll always see some veins there, and sometimes they look pretty engorged. But when you actually manipulate them in vivo in real time, it doesn't seem like they have this tremendous amount of pressure. It seems like they're actually kind of pillowy like, and you're wondering, well, how much pressure is this really putting on the nerve versus, but what you're explaining about this adjacent inflammatory response makes a lot of sense.
Yeah, I mean, with there are certainly MRI and ultrasound cases where you've got a posterior tibial vein thrombosis that has given rise to tarsal tunnel syndrome, and I've seen it on 2 cases.
Right.
Where you can actually see it on the MRI, where there's a lot of inflammatory change in the tarsal tunnel, and you look at it, look at the vein in close proximity to it, and you find that there's actually an abnormal signal in the vein, and when you bring them back for an ultrasound, you see that there's a thrombus. The thing about the posterior tibial vein is that it is directly coming from the plantar venous arch,
right,
which is probably one of the highest pressure arches that is there in the foot. Again, the foot pump gives rise to blood flowing into the deep venous system. So then the calf pump takes over, and then the thigh pump takes over.
Got you. That makes a lot of sense. Yeah.
So it can be, quite common that you find. I think the phlebitis is quite a reasonable thing to think about in this sort of situation. I think that you probably find that if you were to use the 5% dextrose scenario, or you use a microgram dose of cortisone, you'll find that it actually sort of can resolve the situation quite quickly.
So just to circle back on that phlebitis just a little bit, the perception is that it's an intravenous inflammation, but you're also saying that there's extravenous inflammation. And is that due to some of the extravasation because of the tortuous nature of the vein?
Yeah, the vein wall itself can get a little bit inflamed.
Okay.
For some reason or the other. If the clotting cascade doesn't necessarily have to happen for the vein to get inflamed. You can get hormonal changes, as I've said, in the situation of HRT. You can, if you traumatize it, you can also give rise to low-grade vein inflammation. One thing I've learned in the 8 years that I've been doing this is that you don't jig around with the vein too much, because the more you push and shove, the more likely you are to give rise to phlebitis.
Right.
And so, yeah, I think that phlebitis gives rise to periphlebitic changes that microenvironment of inflammation can invariably cause adjacent neuritis.
That's interesting. That's very interesting. So one last question that I have for you, because I know the audience is going to be interested in this, and explain the peri-procedure regimen, because it looks like you're doing these all on an outpatient, sometimes in clinic basis, right?
Yeah,
and so,
all in clinic.
Okay, so give a thumbnail sketch on what the average venous procedure would involve, just so that people know.
To get an idea about that, you just need to go back to the initial consultation. So initially they come in, they have their consult where we chat about the veins. We do a detailed vein map, which gives me an idea of how we proceed. Basically,
and you're doing that with ultrasound?
Yes. Yeah.
Okay.
So,
okay.
Ultrasound is the gold standard for venous mapping. Sometimes in large patients, you may want to do a CT venogram, but vast majority of it can be dealt with ultrasound.
Gotcha.
So once you've got the ultrasound, the two things that you're really looking for is there truncal insufficiency, and where the varicosities re-enter into. So there will be a inflow site, which is often your truncal vein, and an outflow site, which is often your perforator vein.
Okay.
So once you've found out where the inflow and outflow is, then you can go and then deal with this patient. So often, say for example, the previous gentleman that we saw, initially we would do a great saphenous vein truncal ablation. It's usually a 90-minute procedure, and it often is combined with a ultrasound guided sclerotherapy. So that 90-minute procedure, the patient comes in, we mark up the veins on the skin, mark up the entry site, do the femoral nerve blocks, obturator nerve blocks, saphenous nerve blocks, and then go on to cannulate the vein, do the endovenous laser ablation. I often do ultrasound guided sclerotherapy at the same time to deal with the larger varicosities. Then you give them a 2-week break or 1-week break, and then bring them back for completion of the ultrasound guided sclerotherapy to the varicosities. Because by the end of that 90-minute session, although you've dealt with about 70 to 80% of it, you haven't dealt with all of the veins.
So it's just not possible to really get it in one shot.
You can if you give patients sedation, but it's a big procedure. You know, you're looking at a proper 2-hour procedure if you want to do something like that. There's a degree of needle fatigue also the patient goes through. I mean, you're looking at at least 30, 40 needle sticks that you're doing for the patient, you know, starting from the nerve blocks, going down to the Tumescent anesthesia, and then the ultrasound guided injection. So Once we've done that, once we've done the endovenous laser ablation and sclerotherapy, stockings on, they walk for about 30 minutes post-procedure, and then they jump in their car, go home.
Okay.
They wear their stockings, compression stockings. In my protocol, I tend to do it for 7 days.
All right.
So 2 days, day and night. So 48 hours worth of continuous, 5 days of just through the day. That seems to sort out most of the issues. They come back at 2 weeks. Often at 2 weeks, most patients have a degree of mild phlebitis, and that's because the vein is closed. Those veins are closing up. So patients often complain of lumpiness, tenderness, bruising.
Right.
We use a heparinoid cream to try and then deal with that side of things.
All right.
And then the second appointment is a 30-minute or 45-minute appointment where we finish off the last bits of stuff.
Gotcha.
And then we give them a 6-week break and then do a checkup. Very rarely do I need to do any top-ups at that time. And then they go on to a yearly follow-up, basically. So we've dealt with that network. We just need to make sure that, if there are new veins that pop up, we may inject them on the day at that 12-month mark and try and then maintain.
And so what's the biggest complication? Potentially saphenous nerve or sural nerve injury? Is that really the biggest one?
I suppose DVT is the biggest one. So it happens in 1 to 3 per 100 patients. So usually endothermal therapies can give rise to what they call endothermal or endovenous heat-induced thrombosis. It's called E18. Okay, so you can get a little bit of thrombus that extends along the saphenofemoral junction into the common femoral vein itself. And depending on the degree of occlusion, you may want to give them the blood thinners at the time, or you may say, "Oh, look, we'll do a scan and then check it out and see what degree of thrombus has formed." If there is thrombus formed, then we go on to 2 weeks of blood thinners. Or blood thinners are usually a Pixaban or Rivaroxaban or something along those lines. If they can tolerate that. Some people use enoxaparin or one of those sort of things. There isn't.
Have you ever looked at nattokinase?
No, I've never looked at nattokinase. No, I haven't come across that.
Have you come across nattokinase? Because it's actually, it's a natural supplement, but there are some studies, and I can't recall the sightings right now, that show substantial equivalency to, some of the big pharma.
Oh, really?
So it might be something to think about, and
it's
very inexpensive, and I think it's nattokinase actually has some anti-inflammatory properties as well. So it's not so, might be something to look at.
Yeah, absolutely. Gosh, I haven't come across it, so it'll be helpful to.
There's another one that's similar called lumbrokinase, but nattokinase. Hell, you can buy it on Amazon.
Right. Okay.
Yeah.
Wow. Okay.
But yeah. So it's kind of an interesting. We put a lot of folks on it actually. For different reasons, but it definitely has a neuro anti-inflammatory benefit as well.
Wow. Okay. Nattokinase. Okay. I'll definitely look it up.
So you taught me a lot of stuff today, Amit, because, as a lower extremity surgeon, you see this all of the time, but, sometimes it's just the little things that give you the concept, like the pump. The fact that you're dealing with a deep system and a superficial system. And I could never really wrap my head about it. It's like, well, if the valves are bad superficially, they're bad probably deep, it's the same physiological process that's going on in this poor patient, but it makes so much sense now,
Yeah. And you see a lot of men and women who are flat-footed, who've got pes planus, pes cavus,
right,
who are really deconditioned. And a lot of them will have varicose vein disease or venous incompetence because of that. A lot of patients with early Danlos syndrome or connective tissue disorders.
Yeah.
So the it is much more prevalent, and we know that there's a 4-fold increase or 5-fold increase in DVTs in a lot of patients with varicose veins.
Yeah,
So
well, it makes sense.
it's a huge problem that a lot of us have sort of within the medical community have shifted away from thinking of it as something that sort of needs to be at least managed in some form or another,
right.
To saying it's primarily aesthetic, but there's a fair amount of morbidity with a lot of this sort of stuff.
Yeah, that's such an eloquent point, because, when people think of varicose veins, they don't think of the health issue. They only think of the cosmetic issue. So that's a
Correct.
really valid point.
Yeah.
Wow. Amit, thank you so much. I learned so much from you all the time, and I really appreciate you taking the time to come back on the show.
No worries. You look after yourself and have a great day.
Thank you. As you know, I'm passionate about learning new ways to address health concerns. Moreover, before I recommend any treatment or supplement, I always try it on myself. Today, I want to share my experience with Troche. I have investigated other phytocannabinoid formulas and found that, in general, they were not consistent or reliable in their results. What impressed me about the Troche delivery technology is that each rapid-release tab is engineered to provide fast-acting, long-lasting, reliable delivery of phytocannabinoids to support your health and well-being. Many physicians understand the importance of using phytocannabinoids for physical discomfort, sleep issues, and mood. But if the formula is not reliable, most patients will give up, never experiencing the real benefits. I put this to the test on myself and actually tracked my progress. This graph shows my results for reducing stress. Troche is so serious about how well their product works, they partnered with People Science to provide the Troche Tracker health assessment application that lets you monitor your progress and works with you to accomplish your wellness goals. If you are a patient, click the link below and the patient button to register for Troche Tracker. Assess your baseline health metrics and receive a free Troche sample in addition to getting preferred patient pricing on all products. If you are a clinician interested in adding Troche to your practice, click the link below and then the clinician button to register for a wholesale affiliate account, or go to the link above. I hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes found at our website, podofinquiry.com. If you think you might have tickled just a few neurons inside that cerebral cortex, please spread the word to your friends and colleagues and tell them that they need to get spelunking. Also, if you can take a minute to leave a review on your podcast provider of choice, and especially Apple Podcasts, that would greatly help the show and be so appreciated, provided it's positive. And if not, then just keep your pie hole shut and stay down in that cave. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.